Welcome to the Solid Tumor Virtual Education Summit presented by the Massachusetts Medical Society at OMed Live. My name is Dr. Bruce Johnson, and you are turned into a live session called Heterogeneity of Non-Small Cell Lung Cancer, Optimizing Therapeutic Strategies in Subpopulations with Dr. Daniel Costa. I'm pleased to serve as the chair of the Solid Tumor Educational Summit. Over the course of today's program, we'll be talking about the importance of early detection and intervention, as well as the role of selecting and tailoring therapeutic strategies when managing patients with non-small cell lung cancer and head and neck squamous cell tumors. Before we get started, I'd like to remind you that I will be taking questions in real time throughout this presentation. You can send me your questions anytime during the program through the box on the lower left-hand side of your screen. Once again, my name is Dr. Bruce Johnson, and I'm a professor of medicine at Harvard Medical School. In addition, I direct the Dana-Farber Harvard Cancer Center's program in thoracic oncology, which is a cooperative group between the Dana-Farber Cancer Institute, Brigham and Women's Hospital, Massachusetts General Hospital, and Beth Israel Deaconess Medical Center. Our first speaker, Dr. Daniel Costa, is an assistant professor of medicine at Harvard Medical School and a physician at the Beth Israel Deaconess Medical Center in Boston. Dr. Costa?
Thank you, Dr. Johnson. Thank you, everyone. It's a pleasure to be here and kick off this session talking a little bit about non-small cell lung cancer and how to optimize therapy for subpopulations. I just want to remind you that I do have a couple of disclosures that are posted on the slide, but they will not affect my presentation. I always like to start talks about non-small cell lung cancer showing this slide that puts in perspective the toll that this type of cancer has for mortality both for men and women. So it's obvious that in the United States and many westernized countries, non-small cell lung cancer leads cancer mortality, which means that even small subpopulations make a big difference in care. The care of non-small cell lung cancer throughout the 80s and 90s was somewhat thought as uniform, where all cancers fit into one category. So this is, as this pie chart shows, everything was the same. And although we made quite a bit of inroads with the use of this idea, with use of cytotoxic chemotherapies, as shown from some of the larger trials, we hit a therapeutic plateau at around the 1990s where we couldn't get much better at taking care of advanced cases of non-small cell lung cancer than platinum doublets, where you had a response rate that was still quite small at around 20%, and the times of disease control were quite short. This is when suboptimizing and subcategorizing populations began. In the late 90s, it was becoming clear that the two major subtypes of non-small cell lung cancer, here depicted as squamous cell carcinomas and adenocarcinomas, had both biological differences and also clinical differences. And some inroads have been made on improving patient outcomes by knowing these differences. I want to highlight just the approval of two therapeutic strategies over the last decade that have taken into account this subdivision into histologies. One was the approval of bevacizumab, a monoclonal antibody against the VEGF, that was approved for non-squamous non-small cell lung cancers, where combined to first-line chemotherapy, there was a small improvement in both responses, progression-free, and overall survival. So this was a way to select therapies based on histology, and also the approval of pemetrexed, which is an anti-folate cytotoxic chemotherapy that seems to have enhanced efficacy in patients with non-squamous histology. So I think that this was the first sign that patient subselection and tumor subselection was important. But at the same time that this was happening, explosion of knowledge on tumor biology was happening. And we've learned that there is a significant heterogeneity in cases of non-small cell lung cancer. This slide just shows that while we thought before as one disease, is actually many diseases. These are examples of genomic alterations, be it mutations, copy number changes, or gene rearrangements, translocations that happen in adenocarcinomas, the most common histology of non-small cell lung cancer. So you can see, just by looking at this slide, that there is quite significant heterogeneity. And the question is, how do we take this heterogeneity at the genomic level that explains many of the hallmarks of what we know cancer is, and how do we exploit it in the clinic? And that is what I want to talk about, where the field has gone for non-small cell lung cancer within the last decade. And although I'm jumping ahead a little bit, what I want to tell is a story where we've gone, as shown on this slide, from a one-size-fits-all approach where we had very little response as shown on the waterfall plot there to better patient selection where now, as you go to the far side of the slide, we can subtype populations where we can have a much higher response. And this is where I will spend some of the time talking about these changes. My talk, which can be interrupted as dictated in the beginning of the session, will focus on EGFR mutations, ALK rearrangements, ROS1 rearrangements, and then some of the novel biomarkers and gene changes that happened. So the story of EGFR is pointing to this presentation because it really changed the field of non-small cell lung cancer. As many of you know, I'm sure the epidermal growth factor receptor, EGFR, is present in many epithelial tissues and in many epithelial malignancies. It's a transmembrane tyrosine kinase that has many ligands, and once these ligands are activated, activate the receptor, it forms dimers, either hetero or homodimers, that then lead to a cascade of intracellular signaling that control proliferation, cell survival. In cancer, it was thought in the late 80s and early 90s that many cancers had either overexpression or abnormal EGFR signaling, which led to the development of specific tyrosine kinase inhibitors against EGFR. And in this slide, I just showed an example of the firsts that were presented, which included gefitinib and erlotinib. There was a lot of excitement with the development of these drugs. However, the excitement was quickly tempered, as shown in these two large randomized trials, ICEL for gefitinib and BR21 for erlotinib, showing that compared to placebo, our lowest comparator standard, these drugs had a small benefit in the overall population, meaning that if you did not subselect, the improvement in survival was very small. And I like to show this small magnitude in this slide, taken from one of these two publications, that shows how very close to the line of placebo these two EGFR tyrosine kinase inhibitors were. Even the one where there was a statistical significance in the case of erlotinib, you can see that the hazard ratios and the proportion were small. And the overall response rates, the amount of tumor regression was very small, below 10%. However, there were patients that had significant responses. As an example, I can quote one of my personal patients in clinic, which was a woman never smoker with Asian ethnicity that had this miliary pattern of metastatic adenocarcinoma that once was given erlotinib, had a dramatic radiographic and clinical response within very few weeks. So the take-home point that we had from the large clinical trials of these inhibitors, that there were some outlier patients that had significant response. And the question was, how can we understand what these patients have? To cut to a long story that involved many groups, it was found in 2004 that some of these outlier patients harbored in their tumors, in their adenocarcinomas of the lung, mutations within the tyrosine kinase domain of EGFR. As shown in this slide, and I'll show the next slide that will give into perspective the frequency of these mutations, the mutations always cluster around both the ATP and the drug binding pocket. Many of the EGFR tyrosine kinase inhibitors are ATP mimetics, so they mimic ATP, and these is kind of the active part of this kinase. So these were the mutations clusters, specifically around exon 19 and exon 21. And as shown in this easier to understand slide, you can definitely see that the most frequent mutations encompass small deletions within exon 19 of EGFR, around 45% of all EGFR mutations. And then the other most common mutation is a point mutation on exon 21 called the L858R mutation, which are another 40%. So these two mutations, which are called now classic EGFR mutations, classic activating mutations, encompass most of the cases of EGFR mutated non-small cell lung cancer. And this is where we have most of our data to show that these are predictive biomarkers of response to EGFR inhibitors. So I'll focus my presentation on these. First question that comes up are, who are the patients that have these tumors with EGFR mutations, and if there are clinical or pathologic characteristics that can define these.